So today we are exploring healthy aging. And on our panel we have represented the mind, the body, and primary care. Now, although we tend to think about aging as starting in about middle age, we know that it is critically important to think about aging across the lifespan. From fetal development to the health of our young girls, to the health of our reproductive age women, and beyond, most of us being beyond. With this being our 10th year of our luncheon, we've actually been, for many of you who have come over those years, we have been with you for a significant part of your lifespan, and we thank you for that. Now, today we surely can't cover everything, but what we'd like to do in these areas of the mind, the body, and how do we take care of ourselves, really talk a little bit about where we've been, where we are today, and what the future holds. So to get our panel started, we have three very special faculty with us. It's a pleasure to introduce the Director of Research at the Connor Center. She is a professor of psychiatry and of medicine at Harvard Medical School. She is a clinical neuroscientist and an internationally recognized specialist on sex differences in psychiatric disorders. Please welcome Dr. Jill Goldstein. Our next panelist is the Director of Women's Sports Medicine at the Brigham and an assistant professor of orthopedic surgery at Harvard Medical School. She is highly regarded for her accomplishments in education, research, and patient care, and she's developed a world-class program for female athletes, which includes a research component that she'll talk about today. Please welcome Dr. Elizabeth Matzkin. And our final panelist is the first incumbent of the Scheinkoff-Bornstein Chair in Medical Education. She is the Associate Director of the Internal Medicine Residency Program and an Assistant Professor of Medicine at Harvard Medical School. As the Associate Program Director of the Residency Program in Medicine, she's really a part of one of the most renowned programs in the country. She is dedicated to improving how we train young physicians and is pioneering several exciting programs to impact medical education, strengthen primary care, and improve healthcare delivery. Please welcome Dr. Maria Yialamas. So welcome. Maria, I'm going to keep this informal. I'm going to call everybody by their first names. Maria, under healthcare reform, every woman under the age of 65 has the right to what we call a well-woman visit without a copay. Now, a very controversial article was published by one of our Harvard Medical School colleagues recently, and what he strongly argued for was doing away with the annual physical. What do you think?
So I've been getting this question a lot in my clinic, especially after the NPR piece on it. And I'll tell you what I told my patients who asked me about this. I don't agree with it because I think prevention, the key to prevention is actually having a longitudinal relationship with your primary care physician. So it's extremely important to know your primary care physician well, because when you do get sick, if they know your baseline exam, I think they can pick something up quicker and really know what to do when something does come up. I also think the wellness exam is an opportunity to really think about your family history. Did something new happen in a family member that changes your screening? Maybe someone with colon cancer or new breast cancer in the family. Your pregnancy history. Did you have diabetes during pregnancy? And that means you have to be screened more often, and maybe a little bit differently than the standard patient who doesn't have that history. And I also personally think the primary care physician's role is to really look at all the care you're getting from every medical provider. So all your specialists, make sure they're coordinating the care, that what one person is treating you with is not affecting adversely another condition you may have, and also being your advocate to make sure you're feeling better and actually getting better from the care you're receiving. So this Harvard Medical School colleague who talked about doing away with annual exams talked about just an episodic visit covering all of these preventative practices. And I just can't imagine in a 5 to 15-minute visit accomplishing all of that, what I just mentioned. So for that reason, I don't agree with that.
So, and we're talking about aging today and healthy aging. What are some of the concerns you're hearing from women about aging?
As women age, I think there's two things that sort of come up a lot in my clinical practice. One is really maintaining mobility, being able to continue to do the activities you love, whether it's running, tennis, golf, with minimal pain. So how can you really keep yourself active? Alongside that, sometimes also, how do we keep our weights as normal as possible? It gets more difficult as we age. But I think also from the memory perspective, it's a real concern. People feeling not as sharp as before. Is the memory loss that you do have, is that normal, abnormal? Does it mean dementia's around the corner? And how can you actually prevent memory loss or dementia down the road? And those are the major questions I get.
So it's really, so as we've kind of proceeded in the conversation today, it's really the mind and the body. And so I think, Jill, that's a perfect segue. You're doing work on the aging brain. Can you tell us a little bit about women and memory? We know that women are nearly twofold more likely to be diagnosed with Alzheimer's. So what's different with women?
So actually, women have better verbal memory. When I say verbal memory, I mean memory for words, verbal material. Women have a slight edge, and actually the brain regions that regulate memory actually develop differently in the male and female brain, beginning in fetal development. And they develop about 2 years earlier in the female brain than the male brain. And in fact, just post-puberty, there's the emergence of sex differences. Women have a slight edge in verbal memory, and they do across the lifespan, which then attenuates with menopause. In the healthy female brain, women still retain an edge. So, as Paula said, why should women be at twice the risk for Alzheimer's? Well, the field believes that it's only because women live longer. But we believe that that is not the only reason, and that the field, the Alzheimer's field that is, has been really looking at the wrong time. Timing is everything when you're trying to find sex differences. Timing in life is everything, right? Well, particularly with sex differences that they've been looking, their studies have started in general at age 70 and above. And we believe that the clues for understanding which women will be at highest risk for Alzheimer's begins at ages 45 to 60. And we have strategies that we believe that will help us find those clues as early biomarkers for the risk for Alzheimer's. Now, the field actually is going to move treatment into that arena, 45 to 60 years of age, because they feel that Alzheimer's treatments will be more effective before the onset of overt symptoms. So they want to move into that period of 45 to 60. We feel we have innovative strategies for identifying who will be at risk, and we believe that infusing it with our knowledge of hormonal regulation of the brain will be key.
So, I think that we are so poised, really, at the Brigham to make advances in these areas with the Romney Center for the Study of Neurologic Disease, with people like Risa Sperling and Dennis Selkoe, with your work. There's a lot to come. So really, really important. So Liz, I'm going to turn to you to talk a little bit about exercise in the body. Clearly, maintaining a healthy weight is partially exercise, is partially nutrition, and we're learning so much more. It's partially genetics, and so there's brain differences there as well. But tell us a little bit about whether there are sex differences in how we should be thinking about exercise.
So it's clear that there are inherent differences, especially when we look at exercise between male and females. So let's assume we have a male and a female, same weight, and at the same level of conditioning. Women have a smaller cardiac output. We have smaller heart sizes. We also have a smaller oxygen carrying capacity, and that's our ability to basically pull oxygen from the air and deliver it to our muscles. So we basically burn less calories for the same activity level as men. So there is evidence that women do work harder.
So does this actually mean that we do have to work harder to get the same impact?
In some ways, yes.
Oh, my goodness. Now I'm going to ask you also, just in terms of the amount of exercise we should be getting. There's a craze right now where there's the thinking that it's these small, I don't know if many of you might have heard about this, these small bursts of exercise may be better than more continuous exercise, kind of the whole Tabata craze. Is there anything to it?
So first off, the CDC recommends 150 minutes of exercise per week. So that can really be broken down any way you want. This high-intensity interval training is short bursts of exercise within a small rest period, another short burst of exercise. This really builds and works on our anaerobic fitness versus endurance exercise where we go out for a long run or a long walk, and that really builds on our aerobic fitness. One's not necessarily better than the other. The most important thing is you get out there and do something that you enjoy and that works for you. I think the biggest things that I see in clinic really are, one, the women who are very sedentary and flip the light switch and jump on the exercise bandwagon. My advice, go slow. All right? Bone is living tissue, and if you can introduce stress or impact or exercise to it slowly, you're going to avoid injury. If we introduce it too quickly, that's when we have problems. The other biggest problem I see in clinic is our women who overexercise. So overuse injuries account for most of the injuries that we see. And the good thing about that is they're actually preventable. So things to think about. And the last thing I'll say is the most important thing to incorporate into your exercise is strengthening. Preventing lower extremity injuries, we need to do proximal muscle strengthening, hip flexors, abductors, quads. And then for our upper extremity, it's really working on our scapular stabilizers and our rotator cuff. Biggest way we can prevent those problems down the line.
That was a lot.
It's a lot to do.
Maybe afterwards we can ask you to do some demonstrations. The training for the whole group of 400 women. But I think it's so important in terms of thinking about moderating. So, doing more but not too much and really doing it the right way is really important, and being consistent about it. So Maria, when we think about exercise and physical fitness, there's a connection to memory. How do you think about that?
Yeah, so we're finding more and more that exercise can maybe slow memory loss or even prevent memory loss in some situations. So if you think about it, when we exercise, our blood pressures are under better control. We all know that high blood pressure can predispose you to heart disease, but it also predisposes you to something called brain vascular disease, so blockages in the arteries of the brain. And you can imagine if that's happening over the years and very gradually that can lead to dementia down the road. So really, maintaining a healthy weight, exercising can help prevent that. And exercise, in addition to the memory part of it, I also think is extremely important because we're now finding out it helps not only prevention of things like diabetes, but even breast cancer. Now when my patients go to the Dana-Farber for a prevention program, they give them prescriptions, do exercise 30 minutes, 5 days a week, because we know it's very effective even in that setting.
So, if there was kind of one magic bullet, it seems like exercise, physical fitness, physical activity is one of them. And you mentioned the prevention of diabetes, and if you think about how diseases progress and the impact on women, I mean, for example, preventing diabetes is incredibly important for women because women experience worse cardiovascular outcomes. So you're really preventing not only the chronic disease, but so many outcomes that disproportionately impact women. Now, Jill, there's been some data that exercise, in fact, can impact brain aging in a very positive way. What are your thoughts?
Physical exercise is the best medicine we have out there, particularly for brain health. We used to think that we were born with all our neurons, nerve cells in the brain, and as we aged, we just lost these nerve cells over time. But we now know that the brain can actually produce these new neurons, these new nerve cells, really over the life course. And even in our elderly years, there are two brain regions that continue to produce neurogenesis, new nerve cells in the brain. One of those, called the hippocampus, is very critical, plays a central role in memory function. And animal studies have shown that physical activity can actually increase what's called a nerve growth factor that then has a positive effect on initiating new neurons in the hippocampus. So we think that may be one mechanism for how physical health actually can help memory function over time. Another way is that maybe some of you have heard about neuroinflammation, how our brain also can be exposed to chronic stress, which produces inflammatory responses in the brain. Just like if you get bacteria, your immune system has to go after it because you've got inflamed tissue and you need to attack it. This can actually happen in the brain. And when it does so over long periods of time, chronic inflammation to the brain is very deleterious to brain tissue. And physical activity has also been found to lower inflammation in the brain.
So the animal studies where they showed the new neurons, there are sex differences in those areas in the brain too. Is that right?
Yes. So when I said the memory circuitry develops in sex-dependent ways, actually the hippocampus is one of those brain regions which is highly, as we say, sexually dimorphic. It develops differently in the female brain than the male brain. Those differences are, as I said, laid down in fetal development. They then change with puberty, and women actually have a slight edge, slightly larger hippocampus than men.
So I want to point out two things. In these animal studies where they looked at exercise, they actually did include female animals. So that's a good thing. Very good thing.
And unusual.
Right?
And unusual.
That's unusual and not that common. And then the second, I think, important thing is that even though we have to work harder to get the same output as men in terms of the same impact, we may actually be getting more brain power from that exercise.
That's true.
Right? I think that's pretty, I think that's good. So I just want to follow this line of thinking a little bit because for many of us with our iPads, we have games like Luminosity. I have it. I haven't really used it, but just in case. What these brain games? Is there anything to these brain games?
So effortful mental activity is also really key for keeping healthy brains. What do I mean by effortful mental activity? Learning a new language, navigating through a new route like traveling, and even some cognitive training, which is what these brain games are about. And there were some animal studies that really showed that with cognitive training, you could actually produce new synapses, which are new connections between how one neuron or nerve cell can talk to another, right? How they communicate with each other, which is key for brain function. And it was found that effortful cognitive training could actually increase these. So that really led to this whole proliferation of brain games, very big business. And so a number of cognitive neuroscientists got together and said, we better evaluate this to let the public know really what is going on here. And here's what their report in a brief summary said. That these brain games can actually have short-term effects on the task that you're learning or that you're using, like if it's an attention task, it can help your attention. However, it's short-lived, it's not long-lasting, they do not have an effect on overall brain health, and they do not have an effect on Alzheimer's risk.
So I think that the message...
Sorry.
The clear, and it doesn't decrease the risk of other dementias either.
It doesn't decrease.
Yeah, it doesn't decrease the risk of dementias. So I think the bottom line is there is no substitute for physical activity, and sitting on your couch and doing brain games isn't going to cut it.
Well, actually, sitting on your couch and doing brain games is better than just sitting on your couch.
So Liz, I want to return to you because I want to just touch on bone and joint health. And it's so important that, once again, we think about this over the life course. What have we learned that can help our young girls really build a body that can be healthier over her life course?
So I'll start. So staggering statistic, 1 in 2 of every female over the age of 50 is going to have a bone break due to osteoporosis. So, and that's because we're not maximizing bone density when we should. So by show of hands, how many of you are still working on building your bone density, exercise, vitamin D? How many of you? All right, so that's probably most of the room. All right, how many of you, show of hands, are under the age of 25? Okay, so we got a couple. So, unfortunately, you can only maximize your bone density till about the age of 25. All right. So once you've reached that age, what you've got is what you've got, and all you can do is hope to maintain it. So whatever your bone density is at that age, throughout the rest of your lifespan, you want to maintain that and not lose it, which is what happens with osteoporosis, and women lose it faster than men. So we are focusing some of our research now a lot about trying to target our younger females and make sure they are maximizing their bone density. And when we talk about this, it really brings up what we call the female athlete triad. And these are 3 things that really work to help with bone density or work against it. So the first is really nutrition. And we talk about energy balance. And so for our young females, they have to make sure they're getting proper nutrition for whatever activity they're doing. So some of our athletes may need more energy in for energy out. And anyone that has a low energy balance is going to affect their menstrual cycle. And we know that normal menstrual cycle is important for bone health. So don't eat right. You don't have a normal menstrual cycle. You know what? You're not building your bone density. And that's a problem later in life. So we actually have some studies looking at the prevalence of this, hoping to prevent fragility fractures down the road. We're trying to bring awareness to this, and currently just starting some new work with actually Dr. Sherry Blauett, who's here today, we're looking at Paralympic athletes. Dr. Blauett's a Paralympic athlete herself, has also been the winner of our own Boston Marathon. So we're hoping to take this, not only looking at female athletes, but Paralympic athletes, and seeing what we can really learn and hope to prevent bone problems down the road.
So Sherry, it's wonderful to have you here. Thank you so much for being here with us. So I think this is so important. And can you tell us a little bit about the injuries that you're seeing in these women?
So women tend to have higher incidence of a lot of different injuries when we talk about musculoskeletal system. First and foremost, stress fractures, and that goes right back to building our bone density. Stress fractures can be secondary to either poor nutrition, abnormal hormonal things going on, or just overdoing it when you shouldn't be, and that kind of impact the bone I talked about earlier. ACL injuries, 8 times more common in our female athletes compared to our male athletes. The good news is that we can reconstruct the ACL and get our young females back out onto the playing field. The bad news is we can't prevent the arthritis they're going to have 25 years later. And as we start seeing younger and younger females tearing their ACL, I mean, I'm seeing 13-year-olds now where, a few years ago, my younger ones were 16, 17. 25 years from now, they're going to be pretty young with arthritis in their knee. So those are the problems we really face.
And are we able to prevent those injuries?
There are programs, and there are some good studies that have shown that what we call neuromuscular training, which goes back to that kind of strengthening I was talking about, that focuses on our core, our hip flexors, abductors, and quads, is the only thing that we can do right now to try and prevent those injuries.
So, this is so important because preventing those injuries obviously then prevents arthritis, osteoarthritis farther down the line. And we know that arthritis is just a major concern as we age. Maria, what are you seeing in terms of osteoarthritis as the plain kind of arthritis in patients?
Yeah, so it's extremely common, as we all know. I think 27 million Americans have it. And what's interesting is there's a predominance in women, so 60% of those patients are women. And they're doing research to try to figure out why that's the case. There are some studies that show there are estrogen receptors in cartilage, so maybe after menopause, when you lose estrogen, maybe that predisposes you to some of the arthritis. And I think, something that comes up in my clinic is there anything you can do to minimize the pain from arthritis, or even minimize osteoarthritis or delay it as long as possible? And I think a few things that I recommend for my patients, definitely really strengthening the muscles around the joint. So just as Liz has been talking about, whether it's your quads or near your knees, so you actually don't have as much impact on the knee and you protect it. And also I think weight loss. There was one statistic I saw once that for 5 pounds loss in weight, you get 25 pounds less force on your knee, which is pretty dramatic. So I think doing those are really helpful.
And then, for some women, obviously, this epidemic of osteoarthritis does lead to the need for knee replacements. And what are you seeing, Liz, from the surgical side?
So it's true. 60% of the total joints that we're replacing are in women. Some of the studies have recently shown that, women wait longer to have these done. And the problem with that we've found is that women lose more function before they go to the operating room. So even though they reap the same benefits as men when they're done, their functional level after surgery is still lower because they waited longer to have the operation. So there are definitely work being done trying to target women and figure out why are you waiting so long. And most of the time when we ask that, the answer is, well, I don't want to take the time off. So we're also making sure it's not that our, majority of male physicians who are orthopedic surgeons just not offering it at the same time point. And the other thing we do know is that women have more post-operative pain for the first 6 months than our male counterparts.
So I think the sound, do we have the sound coming up? I think the issue of arthritis is, obviously we can do what we can to prevent it, but when you get it, and if it gets bad, do not delay your replacement, because the longer you delay, the harder it will be to truly recover. So I think lots of good information. So Maria, I'm going to go back to a topic that for decades we've been focused on, and that is hormone replacement therapy. And we, in the past 15 years, have seen the pendulum swing from one side to the other. What are you telling your women about hormone replacement therapy?
I was saying that really less is more in this case. So we know through the work, actually here at the Brigham, Joanne Manson's work with the Women's Health Initiative, seminal work really that revolutionized what we do with hormone replacement therapy, that now we don't give it if we can't avoid it. And the reason is because of the increased risk of breast cancer, stroke, and heart disease. The studies really were very clear. Having said that, it really is an individualized decision, and every patient is different. So I do have some patients, because they suffer from very severe hot flushes or night sweats, especially those first 2 years after menopause, where we do give hormone replacement therapy because they just can't function otherwise. So we try non-hormonal treatments first, but if they don't work, sometimes we have to do that.
So, Maria, we're just going to do this from up here. Don't leave. When you do give your women patients hormones, what do you give them?
So there are many different preparations out there, and the one I think is the best are the patches. We know now that when you take oral estrogen, that actually it's metabolized by the liver, and it's probably the products that come out of the liver that cause the blood clots that you can see, the heart attacks you can see, and the strokes. And we know if you have a patch, it bypasses the liver, so we think there's a lower risk of those happening. And I know Joanne Manson is studying that right now, so I prefer the patch. If someone cannot tolerate the patch or decides they don't like the patch, I do give an oral estrogen. And the one I think we know the best is Premarin, which actually is something I don't favor because it's a mix of many different types of estrogen. If I do give an oral estrogen, there's one called Estradiol. It's a pure estrogen, probably mimics closest what we have in our bodies in terms of estrogen, and I give that instead. In terms of the progesterone, a lot of my patients don't like Provera, it causes moodiness and so forth. So what I choose instead is something called Prometrium. It's a naturally occurring progesterone. It's based in a peanut oil, so if you have an allergy to nuts, unfortunately you can't take it, but it causes less bloating, less moodiness, and we think it's safer also for breast health. So those are sort of my strategies when someone does need hormone replacement.
And so at the lowest possible dose for the shortest period of time.
Yeah, definitely
right?
Lowest possible dose, even on the patch. You really want to minimize that. And you try to get away with only a year to 2 years if possible. There's emerging data coming out that now there's a group of women, maybe as many as 10%, that can have severe hot flushes and night sweats into their 60s. We're hesitant to give hormone replacement longer than the 2 years, but I think as we get more studies looking at this population, there may be some patients that need it for a little bit longer period of time than we think.
Last hormone question for you. Yeah. What about, if anybody watches infomercials late at night, you see Suzanne Summers talking about bioidenticals. Yeah. What do you think?
Yeah, so they're everywhere, but I am not a fan of bioidenticals, and I'll give you the couple reasons why. First, the assays they use, so the measurements they use to see what your estrogen level is, progesterone, testosterone, they're just not accurate. So they do these salivary tests, these blood tests, they have not been well validated, and they're just inaccurate, not very good. And then the compounded products that are made as a result of this are not regulated. So you really have room for a lot of error. I think it's better if you want estrogen and progesterone to go through the ways we know with the patch and the Prometrium that I mentioned. And actually the Endocrine Society finally came out with a position paper against the bioidentical hormones for these reasons as well.
Thank you. What is the impact of estradiol on the brain?
Estradiol, so estrogens, as Maria was talking about, come in different forms, and estradiol is the main one that has an impact in the brain. And in fact, even though hearing those things from Maria, estradiol is really key for maintaining memory function. So what about menopause then? Why isn't that? We know that all women undergo eventually at different ages ovarian decline. So what explains some of the variability in women's memory function? And there are a few different ways that we maintain what we call estrogenicity, sort of an estrogenic environment in the brain. One is a little gland above the kidney called the adrenal gland, and that produces testosterone-like hormones that get converted into estradiol, so the brain can use some of that estradiol. Secondly, the ovaries actually can produce these same hormones, these androgens, for up to 10 years after menopause, again getting converted into estradiol for the brain to use. And finally, the brain itself actually produces estradiol. So women actually have a large variability in creating estrogenic environments in the brain to maintain healthy memory functioning. We really need to develop better therapeutics, safer forms of estradiol that can get into the brain, in fact, into specific regions of the brain, and not in the breast and the uterus. And we can do this.
And I know, Jill, some of the work you've been doing is also kind of thinking about mapping of estrogen receptors and really looking at that in terms of the brain with this eye towards therapeutics. So lots more, I think, to come in this area. So the last topic I just want to touch on is personalized or precision medicine. We had a program on this several years ago before it was really the rage. But I think there's a notion out there that at some point all of our genomes are going to be sequenced, that we'll be able to walk in our doctor's office and be told what to do in order to prevent every disease or to cure every disease. Where does women's health fall in this? Is sex going to make a difference as we think about personalized or precision medicine?
Mm-hmm. So this has been the buzzword, of course, and really sort of the future of medicine, and sequencing genes and really understanding our entire genome is a wonderful thing. But it's really not the end of the story. In fact, it's really just the beginning of the story, because those genes need to be expressed. And those genes are expressed under different conditions. For example,
Do you remember the story I told you about the nerve growth factor creating the new neurons in that hippocampus? Well, that's regulated by estradiol. That can be regulated. So estradiol, testosterone, they can get right into the nucleus of cells, the middle of these cells, and they can turn genes on and off. So genes live in a hormonal context. Genes live in contexts of physical exposures, social and psychological exposures, and those things can actually turn genes on and off. And really, it's this field of what's now called epigenetics, sort of the functional expression of genes, that really helps us explain individual variability in both the onset of illness, prognosis, treatment response. And one's sex varies by all of those domains I just mentioned. So we're not out of the picture as yet.
So it's going to be critically important to continue to think about sex, to study sex differences. And it's critical, quite frankly, to the whole field of precision or personalized medicine. And Maria, what do you think about this area in terms of primary care?
So I'm extremely excited about this new area of medicine. I think it's a little early right now to be using it, but I can see down the road, maybe 5-10 years, for me, it's going to really empower me how I treat my patients and do a much better job. I can imagine someone coming in with a medical condition, say high blood pressure, for example, and knowing their genes, I will be able to say which medication is maybe the best medication or best match for them. If I need to choose an antibiotic, does this person maybe have a predisposition to an adverse event to that antibiotic? I can prevent those type of things. But also when I think about the prevention piece of it, that's where I really get excited, because I think it's going to empower us to say, if you have a predisposition, how can we use the environment, our lifestyle changes to really decrease the chance of you getting that condition? And I want to give you an example that I think was really amazing. So in diabetes, there are many, many different genes that can cause diabetes, and that's why it's been so tough to find a really great treatment for it. But there was one gene that was found that when you have increased expression, as Jill was mentioning, maybe 2 to 3-fold, 2 or 3 times above normal, that you do have that increased risk of diabetes. So they randomized those patients to just diet and exercise and then placebo. And the diet and exercise group, the expression of that gene came down to baseline. So you really could prevent that diabetes down the road to a normal level. I think that's very empowering and maybe will be very motivating for us when we're treating our patients as well.
So lots of opportunity. The Brigham is doing tremendous work in this area, and we are really partnering with those investigators, and I think lots of great information to come forward. So I just now want to wrap up, because I want you to leave the audience with kind of your parting thoughts. And I'm going to start with you, Liz.
So I think first and foremost, exercise is really important for our physical and mental health. So the bottom line is, if you do nothing, you will not have any benefit. But if you do too much, you're going to risk injury. So find your happy in between and stick to it. Secondly, don't forget strengthening. And last but not least, just remember, bone health is paramount at all ages.
Thank you. Jill, you're next. And what about you?
Okay. The male and female brain develops differently, and it ages differently. Menopause is a critical period for thinking about the impact of estradiol and the impact of ovarian decline, and we need to think about therapeutics that incorporate this knowledge. Physical, effortful activity is key, as well as mental, effortful activity. And finally, we need to use our knowledge of sex differences in the brain, hormonal regulation of the brain, to develop better therapeutics. We're in the age of precision medicine. This will be absolutely key to get the right drug, the right dosage, at the right time, to the right place, to the right sex.
Thank you. And Maria, your parting thoughts as a leading primary care physician.
So I think it's so important to really partner with your primary care physician, get to know them very well, have a very open and honest relationship about your concerns, your symptoms, your family history, your past medical history. And I think also really having a primary care physician who understands the differences between how men and women present with disease and their risks. And hopefully you got a little sense of that today as well, why that's important.
And I'm just going to add, if anyone here has not scheduled their well woman visit this year, that is the one thing you should do when you leave. So thank you, Dr. Goldstein, Dr. Matzkin, Dr. Yialamas.